A very good afternoon to one and all. Indian Society of Emergency and Cardiac Nurses proudly presents the webinar series, and this time we are dealing with international webinar on psychiatric emergencies. When we speak about psychiatric emergencies, in psychiatric emergencies, there will be an acute change in patient's behavior where their coping mechanisms will be altered, and there will be some severe issues in patient safety. So the focus of this webinar will be on primarily on four major thrust areas. One is on patient safety. Second one is nurses safety. Of course, patient safety and nurses safety are uh, two different sides of a same coin. And third one is effective screening when they are showing this kind of psychiatric emergencies. And finally, the psychosocial support and the treatment aspect of the patient. So today's webinar will be on primarily on the main four psychiatric emergencies. Number one is aggression. Number two, child abuse. Number three is suicide and its prevention. And fourth one is psychological first aid. So I would like to welcome all the participants to this webinar. Now I move on to the next agenda of our webinar, that is the welcome speech. I invite Shatrugnan Parikh, Nursing Superintendent of Railway Hospital, Bikaner, India. Over to you, Shatrugnan Parikh.
Thank you, Jatin sir. On the behalf of Indian Society of Emergency and Cardiac Nurses, I welcome all of you in today's international webinar. We are pleased to have Dr. Deepika ma'am for the inaugural session. For today's international webinar, we have four speakers. We have Mrs. Nimi Patrick, Dr. Abhay Varghese, Mrs. Elizabeth, and Mr. Abin Varghese for today's knowledgeable sessions. I also welcome the most important part of our webinar, our participants, and last but not the least, our committee, which has given a hard work on this international webinar, our organizing committee, and the Academic Council of Indian Society of Emergency and Cardiac Nurses. I welcome all of you once again in this today's wonderful international webinar on pediatric emergency. Thank you and enjoy the session.
Thank you, Shatrugnan Parikh, for your warm welcome. Now we are moving to the inaugural section of the international webinar. For this, we have a renowned person with us, none other than Dr. Deepika C. Kaka. She's a leading mental health professional in the country. She has definitely a lot of accomplishment and achievement in his career. She is currently working in All India Institute of Medical Sciences, New Delhi, as an associate professor. Participants, I am just sharing the slide to introduce Dr. Deepika C. Kaka. Does this visible? The slide is visible?
No. Please
Okay.
do the slide more.
Okay. Wait. Is it visible now?
Yeah, it's visible.
Okay. So this is Dr. Deepika C. Kaka, Associate Professor, All India Institute of Medical Sciences, New Delhi. She has a lot of awards and fellowships. Awarded Amesonians of America Award in the year 1999. In 2006, she has awarded Amesonian of America Award for the best researcher and awarded as top poster in Evidence Live in the year 2013 conference at Oxford University, UK, held on March 13. Awarded Fogarty Fellowship at New York University 2002-2003. awarded Advanced AITRP Fellowship at University of California, Los Angeles, 2007. She is also a prolific researcher. She's a national consultant in 2 projects and international consultant for 5, and journal editorial member for 5 journals, reviewer for 18 national and international journals. She has research projects, 2 national and 4 international projects. She's a research supervisor, research guide in INC consortium, and MD, and for MSc nursing students. She's also the master trainer of GFATM. She is also a district counseling supervisor. Especially, she has done a prolific work in HIV/AIDS and counseling. She has a lot of publications. I mean, in the field of, psychiatric nursing, and also specifically in the COVID era, she has published a lot of good papers, including meta-analysis and systematic reviews. She has 429 citations, chapters and monographs of 10. She has organized more than 12 conferences, workshops, speakers for many conferences. She has received a lot of awards, and she has presented 10 papers abroad, and chaired n number of sessions nationally and internationally. Ma'am, Indian Society of Emergency and Cardiac Nurses takes a special privilege and honor to welcome you as an inaugural speaker to inaugurate our program, and we believe you are the best person in the country to do so. Over to you, ma'am.
Thank you so much, Jitin, for those kind words. I really appreciate your the gesture of inviting me as a chief guest for your inauguration function. Speaking of health, when we talk about health, we generally speak in person, we speak about physical health. But we have to remember that physical health and mental health are inseparable. And if even something goes wrong with us physically, our mental health is affected. So this concept, like when you talk about psychiatric emergencies, I would really like to appreciate the Indian Society of Emergency and Cardiac Nurses for taking up this very pertinent topic, which as nurses, we should be having that open mind that any person, not only a person with psychiatric illness, but any individual who's facing a rough weather or is vulnerable can have psychiatric emergencies. Like to name few, you are talking about suicide, aggression, child abuse. These are vulnerable points like stupor, delirium tremens, any drug-related emergencies. These are all emergencies which we as nurses should be well equipped, should be competent to handle when we see a patient like this coming to a casualty or emergency. Like currently, board exams are going to happen. So there are a lot of students, reporting with panic disorder, students reporting with self-harm behavior. So as nurses, we have to be not having that stereotype mind that only people with psychiatric morbidities are likely to have psychiatric emergencies. Anybody is vulnerable to have a psychiatric emergency. So our role as nurses is that we should be promptly able to identify and give the rightful interventions in order to reduce mortality as well as morbidity. We know that whenever a person has a psychiatric emergency, this situation, the individual's thoughts and behaviors are acutely altered, and thereby the individual can be a potential risk to his life, or can be also a potential risk or be a hazard to the life of people around him. So as nurses, we should be able to pick up this very fast and able to do the rightful intervention timely in order to reduce any kind of mortality and morbidity. So what we can do as nurses is, once we see a patient like that coming to an emergency or casualty or the ward, we have to first do a proper biophysiological assessment, do effective crisis intervention. Medication management requires to be done as nurses, and we can never treat the patient in isolation. We have to treat the patient holistically, keeping and taking into account his support system, his family, inclusion of his family dynamics, and consideration of all the environmental influences, which will kind of play an important or pivotal role in his treatment and follow-up. So there are certain ground rules as nurses which we are supposed to be keeping in mind when we are interacting, when we are treating, when we are taking care of patients' psychiatric emergencies. First and foremost is to see the patient's safety. As Jitin rightly said, it's a very important component to ensure that the environment of the patient is physically as well as psychologically safe. So that requires to be taken into account as nurses. Then we have to maintain, we have to also assess the risk. How much is he at risk of causing harm either to himself or to others? Like in aggression, he is likely to cause harm to himself or to others. Whereas in suicide, there is a high chance of causing harm to self or any self-harm behavior. So we have to also maintain the self-esteem of the patient when you're providing care. We have to be non-judgmental. We have to be supportive. So all these things we have to keep in mind. Our attitude as nurses has to be very positive, especially with patients with suicide or any kind of drug intoxication. We have to have a very neutral, a positive attitude that the patient requires help and not label or judge the patient. And if the patient has a psychiatric detailed history requires to be taken from the family member to ensure what medicine was he taking, what diagnosis he has got, and also maintain and do prompt crisis intervention. And interventions, as per the psychiatric emergencies, the rightful intervention requires to be given promptly and timely to reduce mortality and morbidity. So I would again like to reiterate, as nurses, we should not think that psychiatric emergencies are only for the patient with psychiatric illness. Anybody can be prone or vulnerable to any kind of psychiatric emergencies. So we should be equipped, we should be having the competence to handle any kind of emergency whatsoever. Sometimes there are anger outbursts or aggression among even the workplace. We talk about workplace violence these days. So we have to be prepared and equipped to handle these kind of emergencies and do the prompt at the earliest. So I again like to congratulate the Indian Society of Cardiac and Emergency Nurses for taking up this very pertinent topic. And as I see, the topics are very pertinent, and the galaxy of experts who are really veterans in their field are going to speak and empower you and give you that confidence to handle any kind of emergencies which we keep facing in our everyday lives when you work in the hospital. So I really congratulate and thank you for taking me on board for this very important and a pertinent topic. Thank you so much.
Thank you, Dr. Deepika Sikaka. You have set a right platform for an international webinar, and you have said it rightly that psychiatric emergencies are not only for psychiatric patients. It can happen in any settings. Thanks a lot, ma'am, for giving the consent for inaugurating our international webinar.
The pleasure
Thanks
is
a
all
lot,
mine,
ma'am.
Jitin. It's an honor to be a part of this. Thank you.
Thank you, ma'am. Thank you. Now we are moving to the session of international webinar. The first session will definitely on managing aggression in acute care. We already know that aggression can be seen in anywhere. It's not necessarily that it can be seen in psychiatric ward. It can be seen in any kind of setting, be it in roads. But when nurses are concerned, being in hospital premises, it can occur in any settings. So Ms. Nimi Patik will be dealing with managing aggression in acute care. So meanwhile, I will be introducing here. So let me share the slide for introducing. If it visible, give me a thumbs up. If the screen is properly visible, give me a thumbs up.
Not.
It is not. It is not. Okay.
No, it's okay.
I don't find the option for sharing the full screen mode. Yes, I find it. Okay. So the speaker is Nimi Patrick. She has done her MSc in psychiatric nursing from Rajiv Gandhi University of Health Sciences in 2013. Currently works as a registered nurse in T. Vare Ahuru Acute Mental Health Care Capital and Coast District Board, Wellington, New Zealand. She is dealing with the specific symptoms of mental illness, de-escalating situations, and helping patients to overcome the challenges. She also organizes group therapy sessions, including social and artistic events, promoting patients and mental recovery. I reckon she's an apt person to speak on aggression because she has shown a tremendous clinical skill in managing this kind of aggressive patients. So I welcome Ms. Nimi Patrick to talk on managing aggression in acute care, and you have 20 minutes in your hand. And at the end of the section, participant can definitely, type your queries on the comment box in YouTube. Definitely, we will be taking up the most relevant 3 or 5 questions. Over to you, Nimi Patrick. Nimi, your audio is off. You can on.
To participate in this webinar. Can you hear me?
Yes, yes.
Okay.
Go ahead.
So thank you for giving me this opportunity to participate in this webinar. So as I introduced, my name is Nimi Patrick and I am currently working as a registered nurse in Tifari Acute Mental Health in Capital and Coast District Health Board. So I would like to present about managing aggression in the emergency. Just a moment, I'm just sharing the slide. Can you see the slide now?
Yes.
So because I'm working in an acute mental health facility, so I would like to talk about like something from my experience, and in between I'll just play the PPT also so that you can get an idea about what I'm talking about. So aggression can be anywhere, not only in the emergency settings. Like aggression can be seen anywhere, like in the not only in the psychiatric setting, anywhere. So main thing what we need to do is we need to assess the situation, what's happening. Then we need to find out what we can do on that situation, and we need to make a plan, and based on the plan we need to manage the situation. So there are different types of management method. All the patients do not need any restraint or seclusion, anything. Just we may need some good communication. Just main thing is identify the patient's needs and work accordingly. That's the main thing. So first we go to the definition of aggression. I'll give you like a simple definition of aggression. So according to American Psychological Association, aggression is the behavior aimed at harming others physically or psychologically. So there is a huge difference between anger and aggression. So anger, if a person is angry, that doesn't mean that they have an intention to hurt others. But in aggression, the aim of the person to harm others physically or psychologically. So that's the most difficult thing, like we need to face, because our priority is to maintain the safety. So if a patient has an intention to harm themselves or others, we need to stop that behavior. So in a simple definition, so aggression means they aim to harm others either physically or psychologically. Coming to the types of aggression, there are, or we can say it as a forms of aggression. Like aggression can be very simple, like from verbal to physical. So first thing is the physical aggression. So in the physical aggression, mainly assaulting others, like they use force, our physical force to assault others. This include beating, hitting, kicking, damaging property, etc. So a patient doesn't need to be mentally unwell to do this. Like physical aggression can be done by anyone. Those who with like a criminal or violent background, they can do it. But in the psychiatric settings, it's very common. Physical aggressions are very common. Like they always try to assault
I think there is an issue in the internet connectivity.
Hello.
Yes, Nimi, you are audible.
Sorry.
You
Sorry,
can
there was
continue.
some.
You can share the screen also. You can
Okay.
continue. Perfect.
Okay, so the relational aggression is like aims at harming other people relationship, like spreading rumors, like splitting behaviors, etc. That is not very common in our settings, but that's also a form of aggression. That's all. And another one is passive aggressive stage. That means to allow harm to come to someone. That examples are being dismissive, passing sarcastic comments, etc. Because they are not visibly aggressive but indirectly aggressive. That's another type of aggression. So the main types are physical, verbal, relational, and passive aggressive behavior. And in the psychiatric settings, the most common things are physical aggression and verbal aggression. Coming to the causes of aggression, I can categorize it into three categories, mainly biological, environmental, and psychological. In the biological aggression, main reason is hormonal imbalances. So there are certain hormones that trigger aggression, like any imbalance in the cortisol level that increase anxiety and can cause aggression. And another one is like a testosterone imbalances that may also cause aggression. And another one is disturbances in the neurotransmitters like serotonin, GABA, all these kind of neurotransmitters can also affect the aggression. So this is fairly commonly seen in elderly people with delirium or dementia, because they suddenly change their behavior, and sometimes we may not be able to identify what's going on with them. But the causes are mainly this kind of
Yes, Nimi, you can unmute. Okay. You can share the screen.
So the third is the most important thing is what we deal in the psychiatric settings is a mental health condition. Any mental health condition can cause aggression. This can be from mood disorders or schizophrenia, schizoaffective, any kind of mood disorder, any kind of disorders can cause aggression. So I will tell you an example about mood disorders. For example, if a patient is in a highly manic state. Hello.
Yes, you're audible.
Okay. Okay. So if a patient is in a highly manic state, their impulse control is very less. So that can trigger aggression. So if they are demand for something and if we cannot meet the need of that, they can trigger their aggression. Another one is like another example is hallucination, like hearing voices. If they get like a command hallucination and they act according, hope everyone know what this hallucination is, like a false sensory perception. So if like hearing voices, when they hear voices, that some kind of voices are really commanding in nature, and if they cannot differentiate if it is real or unreal, they act on according to the voices, and this can trigger high risk, very high risk of aggression. For example, if the command voices say that you go and kill that person, they will do it because they are so much guarded with that voices. So that's a very high risk kind of aggression. And any other like psychiatric borderline personality disorders, narcissistic personality disorders, any kind of personality disorders, all because they all are in a high risk of getting aggression. So we need to monitor when a patient comes to the ward, we need to monitor what the risk is. Like, and if they are in a de-escalation side, we need to monitor them like continuously. So we can prevent it. Instead of going into a like very high verbal or physical aggression, we can prevent it by monitoring the patient continuously. We can prevent it. So now I'm going to some of the de-escalation techniques, but what is helpful. So the basic principle of the all de-escalation, like we need to melt down the person. That's a simple word for de-escalation. If we want to melt down the person, so our first priority is safety. Safety include not only the patient safety, our safety also, because we are also coming from a family and we need to go back safe. So our priority is safety. Safety for our safety, the patient safety, and the surrounding safety, all the staff safety, everyone. Everyone is important to us. So the de-escalation principle mainly oriented on safety. So as I said, like where I work or in the New Zealand setting, normally first priority is my safety. Like make sure when we deal with an aggressive patient, we are standing in a safe place and there should be a free exit so that we can get out. So that's the most important priority when we are going to deal with a patient who is vulnerable to aggression or a patient who is aggressive. Our safety is the first priority. So we need to stand in a safe space, and we don't go very close to a person who is highly vulnerable to aggression, because personal space is very important. Don't invade into their personal space. That can also lead to aggression. So give them space, and we need to have a safe exit when we talk to them, and we need to have there should be a safe place also. So that's the first and foremost important safety of us and the patient. So I'll explain it later. So next thing, when we talk to a patient, how we identify that a patient is going to be aggressive. So the patient may start showing some gestures, like they may be pacing around, they may look highly guarded, or if the depends, when we look at the history, they look highly demanding. So there is a high chance that they are going to be aggressive. So when we deal with such kind of patients, we need to make sure that there should be enough people around with us, and be calm and observant. We don't need to interfere too much in the beginning, like be calm and observe the patient. We should, as we all are human beings, we may also get panic. So don't show it to anyone, like try to be calm and observe the patient, give them space and try to understand what's happening. Okay. And next one is, if the patient, then we realize that something, the patient need a help. So next thing what we need to do is like build a rapport, like build an interpersonal relationship with the patient. So that is a tricky part, because some people don't like us to talk with them. Some people like to talk. So we need to assess the patient. So we can just go and introduce themselves and can we have a chat. Then the tone we use, that's some very important thing. Like we need to be in a formal and a respectful tone, and the word we use not in an intimidating way. And the body language, we need to be empathetic. We need to try to understand what's going on with the patient. So we need to be empathetic and we need to stand with them. And our aim is to work with them and try to find out what's happening. And we need to offer some help depend on that. So the building an interpersonal relationship, making a good communication is a very most important thing in managing, de-escalating a patient. So after talking to them, for example, if you can see in the picture, like an older lady is taking some water. Sometimes the reason for the patient is like vulnerable to aggression, mainly because of some physical spaces, physical problems, like they may be constipated or they may be dehydrated. That can also trigger aggression. So when we identify what's happening, make sure the patient get a physical review. If they have like any physical problem that we can solve. And sometimes small interventions like adequate hydration or giving some medication that help for their bowel movement, that can help. So after respecting their personal space, we need to identify the needs and we try to work with the patient based on their priority and needs. So, sorry. So in that I mentioned about medication. Sometimes we can offer them some kind of PRN medication like calming down, like lorazepam or any antipsychotic medication that help for their voices, or any kind of medication support we can give them. That's enough. So by that time, without going into further inference, we can stop aggression. So sometimes that doesn't help. We cannot stop with that one. So next one, patient keep on yelling at us and screaming at us, and they don't want to listen to us. They don't want to take any medication. We identified that we need to do something. So we need to talk to them firmly, like in a respectful way itself, but we need to tell them firmly. This is what the acceptable behavior is, and if that behavior is you are not doing that behavior, we need to explain them about what is the consequence, what is going to happen next. If you are not following the policies of the ward, what's going to happen next. So, and don't let them come into our personal space also. Like we need to put a boundary. You need to stop this. In our settings, mainly we come across like ours is a smoke-free environment, and most of the patient when they come for in the psychiatric setting, they know that they cannot go out for a smoke. So what happened is they come to us like, give me this, give me that. So at that time, what we can do is we need to tell them firmly, this is what we can do, this is what we can help. We can give you like nicotine replacement instead, but you need to follow with what we tell you. That's all, because we cannot when our communication doesn't work, then next step is set some boundaries with the patient. So with these boundaries, sometimes we are able to calm down the patient. We tried the boundaries also, but we need to tell them, you need to take some medication, otherwise it's not going to help. So sometimes patient may take it, sometimes we need to go to the next step. So all our communication, we completed our communication, we trialed our medications, nothing working. Okay, so the patient is going into like a highly restrained, highly aggressive state. They can be verbal as well as physical. So we need to control that situation. Otherwise, what is going to happen is the patient, not only the patient is going to get harmed, the staff is going to get harmed, other patients are going to get harmed. So we need to control the situation. So we need to go something further beyond. So I'm going to talk about restraint. So when our de-escalation strategies fail and the patient is in an uncontrollable aggression mode, we need to start with the restraint. So I'll tell you the definition of restraint. So the restraint is the use of any intervention by a service provider that limit patients, consumers' normal freedom of movement. So restraint is nothing but we are using some kind of force to limit the patient's freedom of movement. Okay, there are many types of restraints we can use. The main three types are personal restraints, physical restraints, and environmental restraints. So personal, you can see in the picture. So we use our body to limit the person's movement. It's like holding the person's hand, or we need to go for like a restraint, safe communication and effective practice restraint training. So we cannot restrain a person without a restraint training, because when we use our body force, there is a high risk that the patient can get injuries. So first we need to go for a training before when we start working there. We need to go for a training like how to restrain safely a patient. So for when we start a restraint, we minimum need like a four to five people to restrain a person, because we need to talk to the patient what is going to happen, and other people restrain the person. So what we mainly use is our body to restrain the people. So that's the personal restraint. And so in the second one is the physical restraint, that we use any devices, but in our settings we don't use any physical restraint, because it is against patient's right, and usually the police does it, we don't do it. Okay, so in the physical restraint we use any devices like belt or ties or like chairs, whatever we can to like restrict the freedom of movement of the patient. That's a physical restraint. We don't practice that. We only use personal and environmental restraint. And another one is the environmental restraint. Environmental restraint means the person is put in an environment that they have access to something, like they have access to toilet, they are in a room, they have access to TV, but they don't have access to any other people, and they have their own music, something like that. So they can access to all these, but not access to other people. So they have a limited freedom of movement. So they can't do much things over there. So they can listen to their music, they can watch the TV or something. That's all. So that's the environmental restraint that we use sometimes. So personal and environmental restraints are the, we find it most effective restraint than using the physical restraint. So we stopped using the physical restraints. So after the restraint, sometimes when we restrain the person, when we restrict the movement, they take the medication and they can calm down. So, and we try to make sure that the patient and the staff is safe, then we can slowly release them and try how they are doing. Okay. But the problem is, like, most people won't settle with the restraint. So we need to go to the next step. That is seclusion.
Nime, you can wind up within 5 minutes.
Okay, so I will wind up in 5 minutes. So seclusion.
Oh, okay.
So after the restraint, we just put people into the seclusion room where a consumer is placed alone in a room or an area at any time for any duration from which they cannot freely exit. So in the seclusion, the key elements are the person is alone in a room and the duration is not an issue. Like we can seclude them for any duration of time, because time is not an issue. Main problem is we need to make sure the patient is safe and the environment is safe. And the seclusion apply, we can do it at any time and the patient cannot freely exit. I'll show you a room. This is how a seclusion room look like. Mainly nothing but we are just locking the door of the patient and let them settle down. And we need to monitor them every 2 hourly, and we need to make sure continuous observation is maintained to the patient. Okay, and we need to monitor them every 2 hourly. After 2 hours, we can assess them. If they are calmed down, we can try trialing out them of seclusion. That's how we do it. So these all are the common techniques we use for de-escalating patients. But seclusion is the last, and it's highly legal procedure. We can't seclude people without any apparent reason. So first try communicating with the patient, offer some medications, and try to distract with the patient. And nothing works, then we need to go through restraints and the seclusion. So this is like a small outline about how we manage aggression, like de-escalate people in an acute emergency setting. Thank you.
Thanks a lot, Nimi Patrick, for your wonderful session. You have covered almost all the aspects of aggression and its management. Anyhow, we have a lively audience. There are a couple of questions coming up. There is one question from Dalang Mapi. She is asking about what is passive aggression?
So passive aggression is informal form of aggression. So in that case, the person doesn't look aggressive. When we look at them, they don't look aggressive. But the problem is when they talk to them, they are really dismissive. They are sarcastic. They make sarcastic comments. So we know that something is coming. So they don't want to interact or cooperate with us. That's the main thing. They may be smiling, but they don't want to cooperate with us. They are passively aggressive. Hope you understood.
Yes, the message is clear. And one more question is from Marvina R. Marak.
Yeah.
Before restrain the patients, we should take consent.
Yeah, for the patient, if the patient should be for restraining any patient, the patient should be in a mental health act. So if the patient is in a mental health act, we need to tell them. We cannot take a consent from the patient because we need to restrain. We need to do it anyway. So we need to tell them what we are going to happen. So if the patient is in a mental health act, we can restrain them.
One more question is from Tripta Pandemam. Can we use chemical restraints?
Chemical restraints, we don't use there. We don't use in New Zealand, in our setting. Anywhere in New Zealand, we don't use chemical restraints. We can give them medications like PRN medications. After restraining them, we can give some antipsychotics or lorazepam kind of benzos or something, but we don't use clinical restraints.
Well, one more question from Sapna Rani. Which restraint is most effective in managing aggressive patients?
That's the personal restraint. It's the most effective thing because when we are holding the person, they cannot move, and because the person cannot move, we can give them medication or something. So, and there should be enough people around, so we are safe also. Everyone is safe.
All right, so that means in New Zealand, you hardly uses chemical restraints. So
We
the
don't use
priority
chemical restraint. We don't use physical restraint. Only personal restraint and environmental restraint.
and seclusion.
Seclusion
Fine.
is the final. If nothing work, then fine.
Then the final option will be seclusion.
Seclusion.
Fine. I think we have addressed all the important questions. And one more question. Repeatedly, they were asking about the causes of aggression, and they were asking first cause, second cause, third cause. Anyhow, it can be. I mean, from determined by case to case. So, what might be the cause in general? You can say for the participants.
In general, so that's very like a complicated question because I'm talking according to a psychiatric perspective. So in a psychiatric perspective, any mental health disorders can cause aggression. I think I explained about hearing voices. That's one of the most important, like a very common thing, command hallucination, like auditory hallucination. So the voices are telling the patient to hit others or kill others or rape others. That's the main most common we experience mainly in auditory hallucinations. We experience patients get really aggressive with the command hallucination. But aggression is a wide topic. Like patient can be aggressive. Sometimes our personality, the narcissistic personality, they can be aggressive without any triggers. They can be aggressive. So in the psychiatric perspective, mainly auditory hallucinations or a patient, if the patient is in a manic stage, then there is a high risk of getting aggression.
Thank you. The message is clear, and you have done with all the aspects of managing patients in an acute care setting with aggression. Thanks a lot for your time, and obviously there are a lot of questions coming up. I think we have addressed all the important questions, and since we are running out of time, we are moving to the next speaker. Thank you, Nimi Patrick, for your valuable time and for your intellectual inputs. So our next presentation is about child abuse, nurses' role in child abuse. I may introduce the speaker first. Is the slide visible?
Yes.
Okay. So now second session of this international webinar on psychiatric emergencies. The second section is on nurses' role in management. Speaker is
Jithin, your voice is muted.
okay. I hope I am audible to all. Oh, the next,
Yes.
the next speaker is Dr. Ebi Varghese. He is a professor cum principal in Shabadi College of Nursing, and he is principal for a decade in Sharbati College of Nursing, Mohindragarh, Haryana. He has also done his PhD in nursing from Marwanjal University, Indore, Madhya Pradesh. His research is also specifically on child abuse, and he is, I mean, has a multiple role in his career. Like he is an examiner for various universities. He is a paper setter, and he goes for inspection. He has a lot of administrative as well as a lot of works in child abuse, and he has published, I mean, research papers in national and international journals. So I invite Dr. Ebi Varghese to handle the session on nurses' role in child abuse. Over to you, Dr. Ebi.
Thank you. Good afternoon, everyone, and welcome to my presentation. First of all, I express my gratitude to Mr. Jitin Thomas for your kind words. I would like to thank the organizers of Indian Society of Emergency and Cardiac Nurses for organizing this international webinar. Also, let me thank all of you for coming here today. I am delighted to be here to given this opportunity to speak about child abuse. In my presentation, I would like to be focused in nurses' role in managing child abuse. Child abuse is a mistreatment of a child by a parent or a caregiver. It may include any act or a failure to act by a parent or caregiver that result in actual or potential harm to the child. Here, it may or may act or a failure to act. The act may be an abuse. A failure to act, that may be a neglect. Here, abuse is when someone hurt or causes emotional stress to someone else. Abuse can affect anyone. It can happen in any kind of relationship, like a friendship, a romantic relationship, or among even family members. Child abuse is defined as variety of harmful behaviors directed against children. It can take many forms. Child abuse in general, it is a psychological problem. Next, we will see the definition of child abuse. According to WHO, child abuse, all forms of physical or emotional ill treatment, sexual abuse, neglect or negligent treatment, or commercial or other exploitation result in actual or potential harm to the child's health, survival, development, or dignity in the context of relationship of responsibility, trust, or power. Here, child abuse is the abuse. It is a mistreatment or hurt done by the adult to children. Usually, these adult will be parent or caregiver or a close relative. It often means an abuse done by a parent or a caregiver to the child. Next, we'll move to demographics. As per WHO, nearly 3 in 4 children aged 2 to 4 years regularly suffer physical punishment or psychological violence at the hand of parents and caregivers. Next, 1 in 5 women and 1 in 13 men reporting having been sexually abused as a child from birth to 17 years. 120 million girls under 20 years of age have suffered some kind of forced sexual contact. In Indian condition, India has the largest number of child sexual abuse in the world. a total of 1,28,531 cases of crime against children were registered during 2020. Here, the major crime heads under the crime against children during 2020 were kidnapping and abduction, that is 42.6%. As per the crime records in India, 2020, crime rate registered per lakh children population, that is 28.9 in 2020. In comparison with 2019, it was 33.2. This crime rate shows that crime rate against children in India is slightly decreasing. Next, we have to see the types of child abuse. Mainly, we can divide child abuse into 5 types. First one is emotional abuse. Second one is neglect. Third one is physical abuse. Fourth one is family violence. And fifth one is sexual abuse. We'll see first one, that is emotional abuse. Emotional abuse involves non-physical behavior that belittles another person and can include insult, put down, or verbal threats, or other tactics that make the victim feel threatened, inferior, or ashamed. Here, abuse is any type that involved continual emotional mistreatment of a child is sometimes called a psychological abuse also. We'll move to the causes of emotional abuse. The causes of emotional abuse may be, first one is parents may have a negative attitude towards their own children. For example, uninvolved parenting. Uninvolved parenting, it is a style of parenting. This style of parenting is by low responsiveness. Parents do not meet their children's basic and emotional needs, or they may fail to meet their emotional and basic needs. Next one is parents perceive their own children and they are unrewarding, and they may feel difficult to enjoy because of their children. They feel difficult to enjoy their own life. And next one is parents perceiving their difficult to enjoy their day-to-day life. Next one is poor parenting method. Poor parenting methods, for example, they may give a lack of support to the child. They may compare a child with other children, or sometimes they may not be giving proper encouragement to the child, or a lack of trust on child, or parents may not give time to their child. And next one is parental mental health problems. Here, mental illness, depression, schizophrenia will come. And next one is drug and alcohol misuse. Here, addictive behaviors will be the one of the causes. Next, we will see a few examples of emotional abuse. Emotional, that is a rejection of love, threatening the child, inconsistent punishment, etc. will be the examples. We'll move to the second type of abuse, that is neglect. Neglect refers to a range of circumstances which a parent or caregiver failed to provide a child's needs. Here, actually, parent and caregiver need to provide care or need to meet their child's needs. It may be physical needs or emotional needs. We will see what are the physical need to be fulfilled by a parent, what are the emotional need to be fulfilled by a parent. Here, what is happening? The parents and caregiver, they are failing to provide their child's needs, these physical needs or emotional needs. First, we will see what are the physical needs to be fulfilled by the parent. That is the provision of food, shelter, and clothing. Next one is adequate supervision of and control of child. Next, ensuring their access to medical care whenever it is necessary. And another one is their educational needs. And parents should ensure that their child is regularly attending the school or what is their academic performance. These and all things come under physical needs. In their emotional needs, means providing care and love, support, or giving a moral and legal guidance will be the emotional needs. Then we'll see what are the causes of neglect. Causes of neglect, first of all, it will come under socio-economic status of the family. Next, that is the number of children, size of the family or number of siblings. Sometimes stress level of parent may cause rejections or neglect. Here, increase the stress level of parents may be the problem. It may be due to the financial problem, family problems, or occupational or vocational stress will be there. Then psychological problems of children and parents will be the another reason. Here, anxiety problem, behavioral problem, depression, or ADHD, these are the things. And next we'll see the last one, that is alcohol and drug misuse. Then we'll move to the third type of physical abuse. Third type, that is physical abuse. Physical abuse means any non-accidental act or behavior causing injury or other physical suffering or a bodily harm. This abusive act towards children can be result from parents. Parents may attempt at child discipline through excessive corporal punishment. Physical abuse is an intentional act causing injury or trauma to another person by the way of a body contact. In most of the cases, children are the victims of physical abuse. We see the one or two examples, that is hitting, shaking, kicking, biting, slapping. This will be the examples. We'll move to the characteristics of parents who physically abuse the children. Characteristics means the quality, feature, or belonging of a person. Means here we will see the typical characteristics of parents who may abuse their children. First of all, the first point is that emotional impairment of parents. It may be because of the hereditary factors, brain disorders, or diet or stress or family functioning. And the second one is substance abuse, that is alcohol or illegal drug usage. And sometimes parents may fail to use the social support. It means there is no focus or support in times of or in need of a crisis. They are failed to use the supportive system, that is friends, family, and others. If there is a presence of domestic violence or family violence, then also parents may physically abuse the children. And last one is the parent itself felt or they had a history of child abuse. In their childhood, parents faced any physical abuse. They may repeat the same to their children. This will the characteristics of parents who physically abuse their children. Then we'll move to the fourth one, that is family violence. Family violence in general, it is a domestic violence, usually refers to a physical assault of children and women by male relatives, usually a father, husband, or a partner. In this situation, man uses violence to control their partner or even children. Here, the man or the male character, they believe that the violence is a male prerogative, and he believes that the victims are responsible for his own behavior. Then what will happen when in a family, if there is any domestic or a family violence? Family is based on a happiness cycle. Families have a proper happiness cycle, as we see in this picture. If there is a family violence, the cycle of family happiness will be broken. Next and last type, that is sexual abuse. Sexual abuse describes any incident in an adult engages a minor in a sexual act or exposes the minor to inappropriate sexual behavior or material. Here, sexual abuses also describes any incident in which a child is coerced or forced do something, that is forced or into a sexual activity by another child. Here sexual abuse, first we discussed from an adult, here from another child. Here a person may sexually abuse using threats or physical force, but sexual abuse often involves a subtle form of manipulation in which the child is coerced into believing that the activity, that sexual activity, is an expression of their love. We'll see a few examples, that is indecent exposure, touching sexual organs, attempted or actual sexual intercourse, and the last one is child prostitution.
Yes, Dr. Abhi, you have 10 minutes more for your presentation.
Okay. We'll see the general signs of child abuse. We can divide according to the type also. So we will discuss on general signs of child abuse. Here, unexpected changes in behavior and personality of the child. Child may be withdrawn or becoming anxious, or they may be aggressive. Poor bond between or a parent or a child, or a parent and a child, or a caregiver. Poor academic achievement. These will be the changes. Next, we'll see the case dignity of a child abuse. This is an Indian scenario study. This case vignette reveals that what are the things we have to understand while discussing in child abusers or management of child abusers, or available supportive measurement. So the measures what we can take. Here we will discuss about child line hospitals, or a child welfare committee, district child protection officer, or a police, etc. And with detail we'll see an 8-year-old girl and her sibling had lost her mother, and their father was not willing to take responsibility of his own child and using symptom to his relative's place. Once he sent both of their children to maternal aunt's home. During outreach of childline team, the team was informed that the girl was very sick and appeared traumatized. She was admitted in local hospital. She was diagnosed with the malnutrition and weakness by doctors. They also noticed some burn mark on her private parts during examination. The team felt that the girl wanted to share something but was reluctant and fearful. Then the childline team approached the local police station. Then child welfare committee, CWC, and district child protection officer for intervention. But despite of their efforts, both siblings refused to speak. Childline team wrote to child welfare committee to provide a chance to counsel these children to then get a counselor. After few sessions, the counselor find out that and she revealed that the maternal aunt used to burn her various parts of her body, especially the private parts, with a matchstick. She used to threaten the siblings that she would kill them if they informed this to anyone. Childline team shared the details to child welfare committee and took the girl to local police station and lodged FIR against the maternal aunt. Police took immediate action and arrested the aunt. Siblings were placed in children's home. Siblings were shifted into a children's home by child welfare committee. Now both children are learning to live a fearless life. Here name, address, details, and place were changed or not mentioned. That is to protect the identity of the child. In this case vignette, we can identify what is the cycle, how it should be taking care of a committee as a nurse, what we have to do, or how it will be working out. Next, we'll see investigation. Investigation, first we'll see the physical examination. Physical examination will detect injuries such as bruises, burns, swelling, retinal hemorrhage. Sometimes there may be internal damage also. Sometimes a bleeding or rupture of an organ may be there. Sometimes we will identify fractures also. Here we have another techniques, that is X-rays and imaging techniques such as MRI or scans that confirm or reveal other internal injuries. Then if you identify a child with wounds that is at different stages of healing, this shows that there is a regular physical abuse or punishment is going on. So it is showing that different stages of healing that you can note. Next, we'll move to management, how we can manage it. Medical treatment for battered child syndrome will vary according to the injury occurred. Here, battered child syndrome, it is an accidental injury sustained by a child as a result of a physical abuse. Next, we'll move to how we can manage. The counseling is the better one. Counseling and implementation of a intervention of a designed plan. Counseling we used to give to parent and guardians. Here, the abused child may be removed from their home to prevent further harm from the child abuser. Here, the abuser and child, again they are meeting. There is a chance to get the child again get abused. So the abuser, abused child should be changed from, as we saw in the case Vignet. Or next one is decision regarding placement of child with an outside caregiver or whether to returning to home. That is determined by one appropriate government agency working under a court system. Based on this is based on the severity of the abuse, likelihood of the recurrence of the abuse also. Both physical and psychological therapy is often recommended to treatment of abused child. For child also, abused child also, we have to give a counseling. Then if a child is having siblings, as we see in the case Vignet, there are 2 children at home. Means here research shows that 20% of siblings of abused children also show some signs of physical abuse. So as a nurse, you have to take care the abused child admitted in your ward or in your emergency, whether they have siblings or whether whether their siblings got abused, any type of abuse. Next, we'll move to the prevention. How we can prevent. The better method to prevent, that is recognizing the potential of child abuse. How and where it will be. Is there any chance? The seeking and offering of intervention, counseling, training of good parenting skills, or before this physical abuse occurs. Then use of educational program to the caregivers and the parents regarding good parenting skills. And most of the parents, they are not aware about the good parenting skills, and they are not aware about the abusive behavior. They don't know what is abusive behavior, but what is good parenting skills. So the educational program should be given for caregivers and parents to teach what is their role in parenting. Then support from the extended family, that is friends, clergy, or other supporting groups we can utilize. Then we'll see the role of nurse. Role of nurse we will see in a 3 headings, that is physical care, emotional support, and role of nursing management of sexually abused child. First, we'll see what are the physical care we can give. The abused victim, most probably there is a physical abuse, means they will reach emergency room. They maybe need a cleaning of wounds or applying a dressing. Or sometimes injury may be severe. That time you need to plan for a surgery or nursing care according to the severity of the injury. The nurse might provide medications for their pain and help to learn with the crutches also. Victims of abuse may need education for self-management. Sometimes the injury, because depth of injury or maybe a broken bone or fracture, it will take time. So victims, the abused child, need an education or counseling for self-management. These are the care they can give. Next, we will move to the emotional support. Empathetic nurse can help to provide emotional support by listening and allowing the patient to express whatever they feel. Be a good listener. You can give emotional support, listening to the abused child, whatever they want to express their feeling, let them express. Then sometimes the abused child may have a bad experience, they may not adjust with the situation. This type of things you can manage. Gift them a stuffed toy to which they can confide all the bad things that happen to them. Sometimes the next things is that the grandparents, the older adult may ashamed to admit that his or her children are abusing the granddaughters. This will be the next emotional support you have to give to the grandparents. Next, as a nursing officer, you can offer opportunity to talk about the feelings of an abused child. If it is necessary, you can refer to a counselor who is experienced dealing with this abused victims. Then we can identify the thing, and we have to remember the thing that you are the first person to recognize the symptoms of suicide intention or abused victim. You may be a counseling role, you may be having a nursing officer role, if you may be working in a emergency room. So you are the first person to identify the depression or a suicidal intent or an abused victim. Then we'll see what are the nurses' role in management of sexually abused child. Here, nurses can play a very important role in the health and welfare of the children who experience the sexual abuse. Here, nurse can provide a critical role in identifying victims of sexual or child abuse, referring these children for care and protecting them from the further physical or psychological harm. Lastly, we will see the laws related to child abuse in India. Section 315 and 316 of IPC. It deals with the death of an unborn child or an infant. In case, the person shall be punished with the imprisonment of 10 years or fine, or both will be there. Next, Section 317 of IPC deals with the abandonment of child below the age of 12 years. In case the father or mother abandoned their child intentionally, then they shall be punished with the imprisonment up to 7 years or fine, or both. Next section is section 366A of IPC. It deals with inducing a minor girl to have sexual intercourse with other person. In this case, the person shall be punished with imprisonment up to 10 years or a fine. Section 372 and 373 of IPC. It deals with selling or buying a minor girl for prostitution and illicit intercourse for any unlawful or immoral purpose. In this case, the person shall be punished with the imprisonment, which may extended up to 10 years and a fine. We'll move to Criminal Law Act 2013. The punishment for rape of a minor girl has been aggravated under section 376(2)(I) of IPC. In this case, the punishment for rape of female below 16 years of age, the person shall be a minimum rigorous imprisonment of 10 years and can be extended up to lifetime imprisonment. And final one is POCSO. It is the Protection of Child from Sexual Abuse, Sexual Offences Act, that is 2012. Usually call it as a POCSO Act. This act was formed to prevent sexual harassment, sexual assault, pornography, and immoral act against children. This act is not a gender specific one. Focusing on safeguarding child's interest and well-being, the POSCO Act 2012 was enacted to protect the children from sexual abuse or a sexual assault or harassment and pornography. Here, finally, one more thing. Here we have one child line number. Child line number is 1098. It is a 24-hour a day, 365 a year, a free emergency phone service number. Children need to aid any assistance. They not only respond to emergency needs of children, but also link them to relevant services for their long-term care and rehabilitation, as we discussed in a case witness. Childline India Foundation CIF is the nodal agency of Union Ministry of Women and Child Development for setting up, managing and monitoring Childline. Thank you.
Thanks a lot, Dr. Ebi Varghese, for enlightening us with nurse's role in managing the child abuse. I was so much curious about the participants' question. I was going through the questions. I am here. I am just checking the WhatsApp for their questions. I've seen some of them. So the one question that has been asked by Shalini Chandu. What are the symptoms of abused child? How to identify whether the child is abused?
This we can identify according to the type of abuse. So last we have seen general signs. Here we can move to categorized. Here, according to the type we can move, according to type we can identify. If it is an emotional abuse, its symptoms may be different. If it is a neglect or physical abuse, symptoms may be different. So we have to clearly identify which type of abuse or what are the chances. If it is a neglect, the child may be unhappy, aggressive, or if there is an emotional abuse, experience difficulties to mingle with or relate with their parents or caregivers, or they may show
Even-
some physical neglect also.
Even poor academic performances and
Sure,
lack
sure.
of parent bonding. This all can be,
Bill-
I mean,
Yes.
symptoms that can be seen in this
Then
type of
if
child.
we are going for sexual abuses, signs of sexual abuses, there are many symptoms that you will be there will be mood swings or aggressive or violent behavior will be there. Then the child may be unhappy, they may be having suicidal behavior. One more thing we have to note, that is if sexually abused children, frequently they got sexually abusers, then their sexual behavior, language, knowledge, these are all are they are too advanced or they are too mature with their age. Means their age will be different, their knowledge, language will be different as compared to their ages.
Thank you. And one more question from Pooja Negi. What is battered child syndrome?
Battered child syndrome, already we discussed, the is physical abuse or physically abused injured one.
Right. It can be in the form of fractures, it can be in the form of bruises,
Sure.
beating, non-accidental
Kicking,
injury.
beating. Yes, bilkul.
Most commonly in the form of physical injury. And Sapna Rani was asking which abuse among children is mostly seen in India. I can say, as per the statistics, physical abuse is more common. That is around 69% as per the Ministry of Child and Women in the year 2007. And we will take one more question. Suman Bhattacharya, sir, what kind of management can be done in case of physical and sexual abuse in case of a special child by caregiver? What are the provisions?
Special child caregivers, we have to identify which type of problem they have. Means special child children, if we are identifying, then we have to consider them what the difficulties they have. According to that, we have to plan.
Right, and then they need to, approach to a special educator, counselor, because the general counseling and the specially able
Special
child
education counsel will be
counseling is
different.
very, very different, and the dealings are also very different because they are specially able children. Sometimes they cannot, they cannot tell. Sometimes they are physically not that much powerful to, enact. So
Yes.
definitely those kind of, special development commission also can help them. And in general, child abuse have a, legal aspect, higher legal aspect, because it's, violation of human violation. So I think so identification is important, and recognizing who is the, perpetrator, that is also very important, because most
Abuser.
commonly parents themselves will be the perpetrator, and the close relatives can also be a perpetrator. So it has to be recognized soon, because it can be seen in their behavior. If you closely observe the child, you can definitely see sometimes physical symptoms, sometimes emotional symptoms, sometimes psychological symptoms, temper tantrums, poor academic performance. All these symptoms can be a sign. And Dr. Ravi Varghese, I should congratulate you for taking a special session, class, covering all the legal aspects and the nurse's role. Thanks a lot for your enlightening session.
Thank you. Thank you.
Now we are moving to the next session, that is about suicide. Meanwhile, I share the slide. I have really finding a difficulty in sharing it. Anyhow, is the slide visible?
Yes.
Thank God. Finally, I have done it right. Okay, the next speaker is Mr. Ebin Varghese. He will be he will be dealing with identifying the suicidal ideation and managing suicide. He is currently working as a lecturer at College of Nursing, All India Institute of Medical Sciences, Nagpur. He is also given the additional responsibility of officiating nursing superintendent, AIMS Nagpur. He is also a PhD scholar under National Consortium of Indian Nursing Council, enrolled in 2019. MSc Psychiatric Nursing from All India Institute of Medical Sciences, New Delhi, in the year 2012. And he has worked almost for a decade in the as a clinical instructor at Bhopal Memorial Hospital and Research Center, India. Research Center under Indian Council of Medical Research, Bhopal, Madhya Pradesh. I must say that he is a prolific researcher and expert in conducting systematic reviews and meta-analysis. He has done a lot of, meta-analysis including aggression, workplace violence, so many systematic reviews. So he is an expert, and he used to speak in many of the conferences, presents paper. So I think he is the right person, and he himself have written a paper on suicide itself. So it's a pleasure to have you here. Indian Society of Emergency and Cardiac Nurses honorably welcome you to present the topic on nurses' role in suicidal prevention.
Thank you, Jitin. Am I audible?
Yes, you are. Yes, you are audible.
My slides are visible.
Yes.
Yeah.
It's visible.
Yeah. Thank you, Jitin, for your kind words. And I, first of all, I thank the Indian Society of Emergency and Cardiac Nurses for giving me a platform to speak on an important psychiatric emergency, that is suicide. So on to my topic. So what is suicide? It is in one word, we cannot tell it is a simple manifestation or a disease in itself. There cannot be a single cause or a single reason attributed to be a part of suicide. It results from a complex interaction of biological, genetic, psychological, social, cultural, and environmental factors, which leads to self-harm. That is what suicide is. So it is basically a combination of multifactorial risk factors that leads to suicide. What is the magnitude of this problem? Globally, we are speaking, it is one of the most important causes of death among the young population. That is around 15 to 35 years. Not only the person who is suiciding becomes a problem, he is affecting 6 other people when he commits suicide. And as from the image, it is clear, as per WHO records, every 40 seconds, someone dies by suicide. That is what the magnitude of the problem is. And more than 7 lakh people die due to suicide every year. For every suicide, there are many more people who attempt suicide. That is, suicide attempters are also more. And one of the most important risk factors for suicide in the general population is a prior suicide attempt. And you can see many of the suicides, majority, around 77% of suicides are occurring in low and middle income countries. And globally, when we are seeing what are the different means that are being used for committing suicides are mainly pesticides, hanging, and firearms. Considering the magnitude of the problem, the World Health Organization has included suicide mortality rate as an indicator in the Sustainable Developmental Goals 3, that is SDG 3. And that indicator, what the indicator tells is that the WHO wants the suicide mortality to be reduced by 1/3 by 2030. And going on to the further on to the suicide, there are some important myths and realities that are associated with suicide. First one, patients who talk about suicide rarely commit suicide. But the fact is that the patients who commit suicide usually give some clue or warning beforehand. So usually we may be the nursing officers or the nurses may be the first entrance to which they will be communicating their wish to commit suicide. So such threats should be taken seriously. Asking about suicide in a patient may provoke suicidal acts. Sometimes we may think that if we ask the patient about the suicide, or if we ask the person the ways of committing suicide, it may provoke a suicide. But the fact is that when we ask the patient about suicide, it often reduces the anxiety surrounding the feeling. The patient may feel relieved and better understood. That is, you are able to relieve the anxiety associated with the particular feeling when you are exploring into the suicidal intentions or ideations of the particular individual. What are the risk factors, general risk factors associated with the suicide? First, psychiatric disorders, mainly alcoholism and drug intoxication, personality disorders, and one of the most important mental disorders, that is mood disorders, that is depression, is contributing to suicide. And physical illness, chronic illness like HIV, AIDS, cancer. And recently we can see that many of the suicides occurred during our pandemic period, COVID-19 era. Many nursing professionals and health professionals had declared their mental health status, and many had suicidal ideations. And you could have observed an increase in the suicidal rates during that particular period. And some of the personal life stresses like failure in the love relationships, bereavement in the family, a family history of a psychiatric disorder or alcohol abuse or a suicide, or society being pointing you for a guilt or you're feeling shameful. And if you're a separated person, a single parent or a widowed person, and if you're unemployed. And one of the most important risk factors is a previous suicide attempt. So in summary, there can be a psychiatric disorder, it can be a physical illness or personal life stresses or family history, or it can be a previous suicide attempt. What is the connection between suicide and mental disorders? Suicide, I have already mentioned itself, it's not a disease or not necessarily the manifestation of a disease. But mental disorders are a major factor associated with suicide. And one of the most common mental disorder associated with suicide is depression. But in many of the cases, the diagnosis or the identification of depression is missed. Why it is so? because people are often embarrassed to admit that they are depressed. As they see the symptoms as a sign of weakness. They think that if they feel that if they go to the consultation, they may think that other people think they are weak. So they will not approach the physician or anyone or a counselor or a psychologist for their symptoms. And other feelings are that people are familiar with the feelings associated with depression and so are not able to recognize it as a disease. And depression is more difficult to diagnose when the person has another physical illness, because many a times, many of the chronic physical illness or physical illness are associated with depression, and it becomes very difficult to delineate whether the symptom is due to depression. And patients with depression may present with a variety of vague aches and pains. Many times, many of the persons, they approach the physician with physical complaints, and the physician may treat them for the physical complaints and they may get symptomatic relief. But after the medication, again, they will start the vague aches. And unlikely, the physician may not be able to screen for a mental disorder. And suicide risk assessment. This is a scale from 0 to 6. From 0 means it is a not distress, and 1 to 6, it is a gradual, a progressive increase in the number of manifestations of a suicidal ideas. You can see emotionally disturbed or a vague ideas of death, vague suicidal thoughts, or suicidal ideas but no psychiatric disorder, suicidal ideas and psychiatric disorder or severe life stresses, or suicidal ideas and psychotic disorder or severe life stresses or agitation and previous attempt. So in all these cases, we need a prior assessment. We should assess their suicidal thoughts, whether they have any plan to commit suicide, and what are the means they are planning to commit suicide. And what we can do, we can listen their problems with empathy. And if they have a mental illness, refer them to a psychiatrist. And if you feel it is a 6-scale suicide risk, hospitalize them, help them in hospitalizing. And one of the most common tools that can be used to screen for mental disorders in a usual setting can be the Patient Health Questionnaire 9, PHQ 9. It is a questionnaire containing 9 items and with a scoring from 0 to 3. And it contains some of the statements that related to your physical problems, like your feelings, related to your sleep, related to your energy level, related to your eating, poor appetite or eating habits, or suicidal ideas, or you are feeling down, or if you have little interest. So based on that, how often you are getting the symptoms, it is being ranked. And this is the way how you are interpreting the total score of it. If you have a score from 10 to 27, that person definitely needs a referral or a psychiatric treatment or a counselor help. That is moderately severe depression or severe depression. And now we will go into the state of mind of a suicidal person. When a person wants to commit suicide, how his ideations or thoughts are. The first one is ambivalence. Ambivalence means either to do or not to do. A person definitely will have a two-sided wish, a seesaw battle, wish to live and wish to die. If we are able to intervene at this point of time and help them, what are the advantages, what are the benefits of being living, and help them to carry on with that crisis, we may be able to prevent suicide in that individual. Second is impulsivity. Suicide is an impulsive act. Impulse means it is a transient process. It may last for a few minutes or hours. It is usually triggered by negative day-to-day events. Usually all suicides, if we are able to overcome the first few minutes and hours, usually when they are able to ventilate it during that particular period, we may be able to prevent their suicide. The third characteristics of their thought is rigidity. When people are suicidal, their thinking, feelings, and actions are constricted. They constantly think about suicide and are unable to perceive other ways out of the problem. That means their feelings and the thoughts are constricted. And when we are able to sit with them, share their feelings, and ventilate out of it, there may be some relaxation. They may come out of their depressive episode or come out of their suicidal ideation. So these are the three characteristics: ambivalence, rigidity, and impulsivity. And what are the feelings and thoughts associated with the suicide? These are the feelings and the thoughts are being aligned side by side. Sad or depressed, I wish I were dead. Lonely, I cannot do anything. Helpless, I can't take it anymore. Hopeless, I am a loser and a burden. worthless, others will be happier without me. These are the usual feelings and thoughts that are being going on into the mind of a person who is suicidal. And if you are able to intervene at this point of time, we will be able to manage it. Sorry for the interruption. So when to ask regarding the suicidal thoughts? After a rapport has been established with the person, when the patient feels comfortable about expressing his or her feelings, when the patient is in the process of expressing negative feelings. These are the different time periods when we can ask a suicidal person different about their feelings or to ventilate their emotions. And how to communicate to a suicidal person. Listen attentively to them, be calm, understand the person's feeling, that is empathize with them, give non-verbal messages of acceptance and respect. Non-verbal messages just means patting them, taking their hand, or talk honestly and genuinely, express respect for the person's opinion and values, show your concern, care and warmth, focus on the person's feelings. And how to ask. There is a sequence of usual questions that can help you to deal with a suicidal person. Do you feel unhappy and helpless? Do you feel desperate? Do you feel unable to face each day? Do you feel life is a burden? Do you feel life is not worth living? Do you feel like committing suicide? These are some of the questions or sequence of questions that you can ask to a person who is in a suicidal crisis. During mobile crisis also, you can ask these questions, but be calm and composed when you are keeping a mobile call of a person who is in a suicidal crisis. And what not to communicate. You should not interrupt the person too often. You should listen to them. You should be a patient listener to the person who is suicidal. And don't become shocked or emotional to their feelings or thoughts. And never make them feel that you are busy. And never try to make any intrusive or unclear remarks to them. And next, going on to the prevention. So, as I have already told, mental disorders, depression is a major common reason for suicide. And improved detection and referral of the mental disorders can help a great deal to prevent suicide. And as a part of suicide awareness, every year, September 10th, we are conducting World Suicide Prevention Day as an awareness into the magnitude of the problem and the methods or how to increase the emotional support of the people to prevent suicide. And there are some protective factors that help you to prevent suicide. Man is a social human being. So as a society, we want a cohesion with everyone to whom we can share our feelings, thoughts, or our ideas. So you need a support from family, friends, significant relationship, your community, your social circle, and integration with the society, and the religion or cultural and ethnic beliefs that teach you how to lead a normal and a happy and successful life. So, and you should have an access to mental health care and services. And there is a caution. Many suicides occur in a period of improvement when the person has the energy and the will to turn aspiring thoughts into destructive action. So we may think that the suicidal period is over in the initial phase, but it is not so. Usually when the person has more energy, when he is recovering, that is an important phase. We should give more caution. That is the time they can commit suicide. There are many helpline numbers available for a person who is in a suicidal crisis. This is a website where you can get a handful of numbers to contact. And you can see all India helplines are there. Kiran helpline is there, 24/7 helpline services. All India Vandrevel Foundation. And in each state, if you go into the Health Collective India, you will have in each state different numbers that will help you for a person who can call 24/7 and get a counseling help if you are feeling any suicidal ideations. And going into the Indian perspective, so which are the states which are having higher rates of suicide? This is as per the National Crime Records Bureau statistics. Maharashtra leads the top, then Tamil Nadu and Madhya Pradesh. These are the leading states of higher rates having higher commitment of suicide. And looking into the causes of suicide, in the Indian scenario, family problems contribute the most, around 33.6%, followed by illness 18%, drug abuse or alcohol addiction 6%, marriage-related issues, love affairs, bankruptcy, unemployment, failure in examination, professional or career problem, poverty, death of dear persons, property disputes, suspected or illicit relation, fall in social reputation, and impotency. These are some of the causes of suicide in Indian context. And these are the different ways of committing suicide in the Indian scenario. And among them, the most important ways of committing suicide in Indian context is by hanging. Around 53.6% does by hanging, or followed by poison, and then by drowning. And this is one of the case witnessed. You may have read a report about Dr. Archana Sharma who committed suicide. According to the reports, a 22-year-old pregnant woman was brought to Anand Hospital run by Dr. Archana Sharma and her husband. Though she was taken to the labor room, her condition deteriorated and she died due to heavy blood loss. Following this, the relatives of the woman charged Dr. Sharma with medical negligence and created a ruckus at the hospital. They protested against the doctor couple and booked them under Section 302 of the Indian Penal Code. Dr. Archana Sharma, unable to handle the pressure, hanged herself in a hospital room and left a suicide note in which she mentioned that the patient had died due to postpartum hemorrhage, post-delivery, a non-medical complication. Her suicide note read like this: I didn't commit any mistake. I didn't kill anyone. Please do not harass my family and my children. The patient died of BPH, a non-complication. Don't harass doctors, please. My death will perhaps prove my innocence. The handwritten note read. So this is one of her suicide note left by her. And if her family support was there properly during that period of crisis, sometimes we would have able to avert the suicide of that particular doctor, Dr. Archana. So as human beings, we have a responsibility to care for humanity. Expressing concern for others brings inner strength and deep satisfaction. As social animals, human beings need friendship, but friendship doesn't come from wealth and power, but from showing compassion and concern for others. Thank you. Thank you for your patient hearing.
Thank you, Epin Varghese, for your thought-provoking session. There are a couple of questions. One question has been asked from Dalan Mapi: how we can provide or advise persons who is going to suicide?
So the basic principle in counseling any person who is going to commit suicide is being an empathetic listener to them. Don't interrupt too often. Try to understand what they want to tell and listen to them patiently.
Okay, the message is clear. That means active listening is the major component.
Yeah,
so that
active listening is the major way.
Right. Then we can identify where is the issue, and there will be ventilation.
Yeah, actually, the person who is committing suicide, they don't definitely 100% need to want to suicide. They are in an ambivalent stage, whether to die or whether to leave. So if we are able to support them at that point of time, they may be able to get prevented from committing suicide.
One more question is sunborn syndrome. Is suicide is caused due to hereditary reason?
I didn't get you, son.
Is suicide is occurring because of hereditary reason?
So as per the research data, suicide, family history of suicide is also attributed as a risk factor, but we cannot tell 100% if a person is having a history of suicide, that person will commit suicide. We cannot tell that because suicide is a complex phenomenon occurring due to multiple causative factors.
Right. Multi causation is there.
Yeah. If the person has a heredity associated with some risk factors along with that, then he or she may commit a suicide.
Fine. How to identify people going to suicide? A question asked by Karmik Dirji.
Definitely, a person who is going to commit suicide will give a definite warning to it, or a suicidal threat, or he may be withdrawing from his life. Any signs you can identify, or else you can use a PHQ-9 screening test for him if he is suffering from some mental disorders. It is a test, the screening questionnaire that can be used by anyone. And by that, we can identify if he is having any definite suicidal ideations. That is a way we can find out whether the person is suffering from any illness.
One more question by Amanda. Not all suicidal patients have depression, like the last case that was discussed. In those scenarios, what kind of counseling can be given and what kind of intervention?
Yeah, it is true that all mentally ill disorder patient, depression is not only the cause. There are many other factors. Maybe I have already taught personal life stresses, as maybe failure in a bankruptcy. You can see from the figure of Indian perspective, what are the different causative factors. There may be failure and marriage problems. Marriage problems is an important area where many people commit suicide. So if we are able to give support from the family, adjustment is an important area where people fails. So if we are able to identify what is the particular reason they are having and we are able to intervene, it is well. And that means we want to identify the particular reason for their suicidal ideation.
Thank you, Ebin Wagis, for taking a wonderful session.
Thank you,
Yes.
Jitin, and thank you, the organizers, for inviting me and giving a chance to present my ideas on suicide. Thank you, everyone.
All right. Is my slide visible?
Yes.
Right. Okay, we are moving to the final and fourth session of the international webinar, that is nuances of psychological first aid. The speaker is Elizabeth Mathai Varghese. She is currently working with Solent NHS Trust, United Kingdom, as a senior mental health nurse in psychiatric intensive unit as well as acute ward. He also worked as a clinical instructor at Apollo Hospitals, Ahmedabad, before moving to UK. He was also worked as a senior nurse in Neuro ICU at Wockhardt Hospital, Rajkot. She has done her master's in psychiatric nursing from CMC Vellore. Also worked as a chief nursing superintendent at Rajkot Cancer Society. Regional infection prevention and control program in Gujarat during COVID-19 pandemic. Her contributions was specific and much more relevant. So over to you, Elizabeth, for taking up the session on the nuances of psychological first aid.
Thank you, Jitin. Am I audible?
Yes, you're audible.
Thank you. So is my screen visible?
Yes.
All right. Thank you. Okay, good afternoon, everyone. I think we have heard so much, and this is the last topic, and I'll make it short and sweet, and so we can discuss more and see how psychological first aid is important to us as nurses. So we're living in a world after COVID-19 that disasters are very often. We're dealing with earthquakes, we're dealing with floods, we're dealing with a pandemic from almost 3 years, and a war is going on right now. So I would like you to think about how we can help people who come through our hospital doors, understand them better in the situations that they're going through. I believe every time someone walks into a hospital, they're not happy. It's very rare they come in through hospitals when they're in a good situation. So how can we support our patients, and how can we support the society in general when a disaster occurs? So disaster can be anything. It can be a man-made disaster or a natural cause to it. As we see, one of them is a forest fire and the other is 3 years. So moving forward, how do we respond to a disaster. So we have supplies, we had squirted into hospital rooms so that pandemic. So we get ready physically to take over the disaster that has happened. The next is financially. So when we say financially being ready for a disaster is making sure that budgets are allocated, making sure that we are providing enough care wherever it is necessary. So, and the third one, the most important one, is psychologically. So how are we being ready psychologically? To make sure that we are there to support the people during disaster is what is psychological first aid. So anybody can do it. It can be done anywhere. So why as nurses, we're learning this? Because as nurses, we should be very clear, how are we going to help people in disaster? So moving forward, the first definition is from Sphere and Isaac. It says, psychological first aid describes a human supportive response to a fellow human being who is suffering and who may need support. So it's very simple. It's not complicated to understand. It's something that you do when you just sit and listen and help people in difficult times. The next is, it is an evidence-informed modular approach to help children, adolescents, adults, families in the immediate aftermath of disaster and terrorism. Individuals affected by a disaster or traumatic incident, whether survivor, witness, or responder to such events, may struggle with or face new challenges following the event. So we're there to provide a link so that they can get back to their normal life rather than ending with PTSD. So this is something that psychological first aid comes into play, is helping them back to heal, to normalize into their life after a disaster. So what does psychological first aid include? So providing practical care and support, which does not intrude. So if we're dealing with someone who is devastated after an earthquake, who is sitting and crying, looking at the house that has just collapsed, we cannot go and sit next to them and say that we can build this up. We don't know their story. We don't know how it has happened. So, and what if they're not ready to listen? So make sure that it is an environment where they're ready to accept also, and it doesn't feel like you're intruding into their privacy. The second is assessing needs and concerns. Making sure that, are they physically hurt? Do they need an emergency treatment at the moment? Do they need to be referred to higher centers? How can we help them? Is there any other concern? The third one is helping people to assess basic needs, for example, food, water, and information. Whenever a disaster occurs, food, water, and information is very scarce. People don't know where to get it from. People don't know what to do next. So helping them to understand how to access these basic needs would be the best thing you could do at that time. The next is, and the most important part, is listening to people and not pressurizing them to talk. We're not there for a history collection. We're not there to know what has happened and how it happened. We're just there to listen, what they want to say. And being a nurse, that's the best thing you could ever do for your patient. So comforting people and helping them to feel calm is the other thing. It's chaos, I agree, it's all around. And to make them feel calm is one of the most important things that we could do. Making sure that they have a safe environment when everything around them seems to be collapsing. The next is connecting people to information, services, and social support. So we need to have proper information regarding helplines, government plans that are in place where they can find help, how we can associate with them, and how they can be linked to it. And the last is protecting people from further harm. A disaster has already occurred. So understanding the intensity of that and making sure that they do not end up in the same situation or something that would aggravate that is very important. So we make sure that the individual is safe and they are in an environment where no further harm can be caused to them. So moving on, who and when would psychological first aid be useful? Psychological first aid is for distressed people who have been recently exposed to a serious crisis event. You can provide help to both the children and adult. PFA is designed to reduce the initial distress caused by traumatic events and to foster short and long-term adaptive functioning and coping. People who need immediate physical health needs should be transferred to higher centers. So identifying what is in front of you. You treat what you see is the key to PFA. So whatever is in front of your eyes, make sure that you treat that. Help them to have positive coping skills, make sure that they adapt in a better way from the disaster that has happened to them. And they could be in a shock. The initial traumatic events could be really difficult to deal with, but making sure that they're supported properly. And the other thing is immediate physical health needs. Making sure it's kind of a small triaging that you do in your mind, making sure we all are nurses. We all critically think all the time as soon as we walk into a ward. So that is what was needed over here. That is what is expected of us, to triage and make sure that we categorize what is important, what is priority, and take that decision, help the patient to make that decision and move them to higher centers. So making it very simple. It does not need any clinical settings to provide psychological first aid. So it can be an area where the incident has occurred, where the disaster has occurred. It could be anywhere. It could be your accident and emergency department where the patient is coming to meet you for the first time. The next is the only criteria for psychological first aid is we need to have privacy. We need to respect the dignity of the patient that is there with you, make sure that they feel safe and they're comfortable disclosing the painful traumatic events that they have had through. And the third is anyone with a basic knowledge can do a psychological first aid. It is very simple. It is not complicated. So I believe as nurses, we all have finished so many of our OSCEs. We have done so many of our trainings. The first thing is to provide psychological first aid to the patient. So when we have been, when we go for a procedure, the first thing we would do is explain the procedure. The reason why we explain the procedure is making the patient comfortable. It is providing a psychological support to the patient. So that is what we are doing over here. But for someone who has gone through a traumatic event is what we are doing. Moving on, helping responsibly. The first thing is respect safety, dignity, and rights. Make sure that you approach them in a way that they feel comfortable with you, secure with you, and supported, rather than being challenged in a situation that they're finding it difficult to adjust. The second thing is adapt what you do to the account of person's culture. Make sure that we are adapting to how their cultural beliefs are. We would discuss that in detail in just a short while. The third thing is be aware of the other emergency responses measures. As I said, if some patient has to be transferred to a higher center, make sure that you prioritize, critically analyze, and take up the decision and support them to move forward. The fourth is look after yourself. So moving ahead, the cultural aspects, as I said, we would discuss in detail. The first thing is dress, how appropriately and culturally we're dressed. There's a very famous saying that be like Roman when you're in Rome. So that means to adapt to the place that you are. So I had an opportunity to study in different states in India. Each state spoke a different language. Each state approached different subjects in a unique way. So understanding the culture where you are and what you're trying to provide to the person is very important. The language that we speak. I had to learn different languages as I had to do my studies in different states, because that made it very easier for your patient to approach you, to speak to you if you spoke their own language. The third thing is gender, age, and power. If I would like to elaborate on that, it means there are times where the dynamics, the male and female dynamics doesn't work. A gentleman would not be happy to have some support from a woman, or he wouldn't want a woman to see him when he's distressed or is in complete shock of the disaster that has happened before him. So we need to understand that and make sure that instead of a female psychological first aider, it could have been better if a male would have taken up that role. And all that we are trying to facilitate at this moment is comfort, safety for the individual who has been through a traumatic incident. touching and behavior. So in certain cultures, they're very comfortable in patting the shoulder or hugging or making sure that the individual is comfortable. And in certain cultures, it's frowned upon. So understanding the group that you are catering to is very important, beliefs and religion. So we come from a very diverse country where we have so many religions, so many beliefs. And as I said before, making sure before approaching your client, how you're going to do it, and is it acceptable in their religion? Is it acceptable according to their beliefs? Because we do not want to cause any more discomfort than that they are facing at the particular moment. Moving on, responding in emergency situations. The first one is follow the direction of relevant authorities managing a crisis. So normally when we have disasters occurring, we do have disaster coordinators. They do have a fixed plan when something like this happens. So you might have police, you might have ambulances, you might have teams who are ready to evacuate, you might have army over there. So make sure that you follow the directions and guidelines that they have provided so that you're causing no harm in that situation. The second one is learn what emergency responses are being organized and what resources are available to help people. Making sure that where they can call, where they can find food, water, or more information is very important, because as you are going through, as we're going to discuss what PFA does, this is very important. You need to have the basic information with you, only then you can help someone in a situation of disaster. The third thing is don't get in the way of search and rescue of emergency medical personnel. As I said before, there could be a team specifically over there who is doing all of this. Make sure that you're causing no harm or distraction in their way, because that has to be done in a particular, and make sure that whatever you're doing is not stopping or hindering the flow. The next is know your role and the limits of your role. So we cannot prescribe anything on to provide any clinical advice when a disaster has happened. Moving on, how to provide PFA. Good communication with people in distress. As being a nurse, having a good communication skill is very important. As a nurse, when I had begun, I thought when you say about communication, it's more about speaking. But as I progressed being a nurse, I realized it's more about listening. So, and listening actively to your patients. The next is preparing to help, making sure that you are safe, you have everything in your capacity to make sure you have a safe entry and an exit from the place of disaster. The third is the PFA action principles of look, listen, and link, which would be discuss, ending your help, and people who are likely to need special attention in crisis situation. We will be discussing all of this in detail. So moving forward, preparing to help. We need to have a clear idea about the crisis event. When it has occurred, what is the intensity that it has caused damage to? How many people are affected with it? How many of them are children? How many of them are adults? And is it safe for you to be there? The second one is available services and supports. You need to be sure about the ambulance supports that we know. We need to be sure about the hospitals that are receiving patients for mass casualty. We need to be sure about the places where they can have an easy access to food and water, which would be very scarce in a disaster situation. And the most important thing is where they could access to medications, to treatments, and is it free, or is it going to cost them, or is there a charitable trust who is happy to help and support them? So having a knowledge about the available services and support as a time of disaster is very important. The third thing is safety and security concern. As a first aider, the first thing taught is you should be safe. And you should look if the situation around you is safe to go ahead and help, because we do not need to add to the casualty. We should make sure that you're safe to in and exit the place. You have an easy access to it, and making sure you are safe at the end of the day is very important. This is the first step of the psychological first aid. So making sure you are safe. Moving on. action
Elizabeth, you have
principles.
5 more minutes to conclude.
Yeah. So the action principles is look, listen, and link. So moving on, what are we looking for? So we're looking for the symptoms of crying, sadness, depressed mood, grief, anxiety, being guarded or jumpy, worrying that something really bad is going to happen, insomnia, nightmares, guilt, shame of having been survived or not having been able to help enough the others. And what are we listening here? Giving the person your undivided attention, truly hearing their concerns. It's not just like brushing off, or you've heard this a lot of time, but making sure you're hearing it with your whole heart at the point. The next one is caring and showing respect. They are going through a bad time and making sure that you understand and you support them through the crisis. The next is listen, approach people who need support. Ask about people's needs and concerns, making sure that you understand what they're saying. And the last is listen to people and help them to feel calm. It is a chaotic situation. So making sure that they understand and you support them to have a more stable, a calm environment is very important. So when you're listening, keep your tone of voice calm and soft. If culturally appropriate, try to maintain some eye contact with the person you talk to them. Remind the person that you are there to help them. Remind them that they are safe and it is true. If someone feels unreal or disconnected from the surrounding, it may help them to make contact with the current environment and themselves, make them understand where they are. It is very often that they lose track of what is happening at the moment when they are in shock. So the next is link. The third most important part is help people to address basic needs and access services, help people provide with problems, give information, connect people with loved ones, and social support. So the most important thing is look, link, and listen. These are the three main principles of psychological first aid, and that's what we keep in mind when we meet people. Next is for children, keep them with loved ones, make sure that they have a safe environment. Listen, talk, and play. There's a change how we approach with children, make sure that they're addressed and supported and understood in times of this. So how do we end it? After linking the individual to facilities that continue to provide them with help. So there's a continuity of treatment that is being dealt at the moment, making sure that they have adapted to the change, allowing them to positively cooperate with it. The next is, how do we implement a clinical PFA in clinical setting as a nurse? So when a patient walks in through the accident emergency unit, we support them. When they walk in through trauma units, we are there for them. When they're walking in through burn units, any situation where a patient is going through trauma, assault, or an unknown situation where they would need support, we should be providing them with psychological first aid. Moving on, the carer or the first aid provider should have a safe work-life balance. Make sure if the situation or the crisis is difficult, you're talking to some colleague for support, acknowledge the events that has happened, learn to reflect how you can improve, how helpful it has been, and take some time to relax and rest before you join back your duties. So there's a small case scenario that it is about an earthquake of 7.7 magnitude. There were loss of life, mass destruction, unsure about safety, and chaos around. So this is something that had happened in Gujarat in 2001, January 26th. So I come from Gujarat, and this is something that had happened, and I'd been part of it. It was chaos, it was uncertainty all around, and I wish we had a team of trained nurses, professionals down on the floor doing PFA. So we learn from our past is something. So this is how we would have gone forward. Is it safe enough to be in the crisis side? Who maybe need special help? Where can it be provided? What services and supports are available? Are there people with obvious serious emotional reactions? This is how we would proceed. We would be there to listen, have basic need met, have support the people who are affected. How can I best support, comfort the affected people? So this is what is expected of us if you're doing psychological first aid. I hope this session was good. And is there any questions? I would be happy to take them.
Yes, Elizabeth, you have nailed the show. A very good presentation. You have
Thank you.
covered psychological first aid in a glance. So we will definitely go for the questions now. We have a couple of questions. Before that, I have a request for the participants. Participants, are you ready for that? You know, Indian Society of Emergency and Cardiac Nurses conducts a lot of international webinars on disaster in different, specialties. So I request
Okay.
it will be a huge motivation for the Indian Society of Emergency and Cardiac Nurses if you can subscribe our channel. Our channel name is ISECN, that is Indian Society of Emergency and Cardiac Nurses Learning Hub. So subscribe the channel and type yes in the comment box. I repeat, subscribe the channel ISECN yes Learning Hub and type yes in the comment box. Okay, we'll move on to the questions. One question is ready. I am taking up the question. The question is from Dalang Mapi. Has disaster occurred already? How will you handle the victims?
When disaster has already occurred, as I said, it's a collaborative team that we're dealing with. It's not just one person. So the psychological first aider needs to understand that they're not the only one who is responding to. You already have the police team, you have the hospitals, you have the ambulances already been there. So it's a collaborative effort. You are just there to listen, to debrief, to make sure that it is less traumatic for them. That's the only role that we are. And as I said, we are supposed to move them to higher centers, critically analyze the situation, and make sure that the need and the help is provided.
Yes, sir. So you said it exactly right. That is not a one-man show. There is a teamwork which comprises of different mental health professionals. Even you have quoted the example of Gujarat earthquake. Recently, in 2018, in my own state in Kerala, there has flood disaster. So disaster is India is
Yeah.
actually a disaster-prone country.
Yes,
And
yes.
there is, you have said about the mental health professionals. There are medical teams goes there and conduct medical camps and screen. Even the mental health
Yeah.
professionals from Nimhans Bangalore have gone immediately after disaster. Yes, their mental health is taken care. I don't know the
Yeah.
what extent, but the long-term mental health aspect, how much they have addressed, still not clear. And second question for you is from Amanda Tolur. Is it necessary for psychological first aid to be completed within a particular time, or it can be done with a continued session? In such cases, can referral be given?
Yes, absolutely. The most important part of psychological first aid is linking. So you cannot be always there with the patient or the person who has gone through a disaster. So you're linking them to a higher facility where they could go for therapy sessions, where they could be supported by a psychologist. You're just there to assess, make sure what they need and how they can be referred to a higher center. So yeah, I hope that answers the question.
Right. Thanks a lot, Elizabeth, for taking up the session. Really wonderful presentation.
Thank you so much.
Thanks a lot, Elizabeth. And I have requested the participants to do something, that is subscription of our channel, that is Indian Society of Emergency and Cardiac Nurses, that is ISECNS Learning Hub. Many of you are typing yes, I can see you. Meanwhile, we will be sending the post test also. And before that, we have some of the announcements from our society on the behalf of Indian Society of Emergency and Cardiac Nurses. That is, you might have undergone a lot of courses, webinars conducted by the society. And I can say that some of you have got the certificates. And the last two webinars, the pediatric webinars, in case of pediatric webinar, all the certificates have been dispatched. Patient safety is still in process. We are actively doing it because of the overwhelming participants. We are finding it difficult to send within the time frame, but definitely we'll be sending it soon. And neonatal, definitely we promise you by this end of this month we will be sending it. And be stay connected and stay safe. This is all from the center, and thanks a lot for your active participation. Thank you. Thank you all. And I also wanted to thank all the speakers. I mean, Dr. Epin Varghese, Elizabeth, Nimmi, for putting up a wonderful show. And I also thank Dr. Deepika Sikaka for giving the guidance from the stage of conceptualizing, designing the webinar. He has been a constant support, and also especially for inaugurating the webinar. The society is really thankful for you for the valuable contributions, ma'am. And I express my gratitude to one and all once again, and thank you all. Anything else to be conveyed from the society?